Hello? Hello.
Good morning.
Morning to you, doctor. I'm the one. I'm going to present multiple endocrine neoplasia, but usually known as the men syndromes. So these syndromes are usually inherited, and they can be both malignant or benign, affecting different organs. So we are talking about two types that have been described in two types, depending on the organs that they are affecting, and also the genetic component in each of the syndromes. So they are usually autosomal, meaning they don't express their characteristics in the recessive combinations. So men one, this one, we are looking at majorly three organs that are being affected. That is the pituitary, the anterior pituitary, and then you have the enlargement of the parathyroid glands. You have also the pancreatic duodenal endocrine tumors. That is what comprises majorly men 1 syndromes. That is multiple endocrine neoplasia type 1. So I hope we can remember this very well, the three, because when we reach a certain stage, we shall also discuss the sporadic ones, the ones that are appearing either in the pancreas or pituitary or parathyroid, but they are not specifically a mutational tumors. So, but for you to classify them to be type men 1, they must be appearing in these three organs. That is the pituitary, the parathyroid, and the pancreatoduodenal areas. So it's usually a germline mutation in menin gene, that is chromosome 11, unlike men 2, which is chromosome 10. So men 1, they are very rare, up to around 0.2 cases per 1,000 population. However, whoever is a carrier has a 100% chance of developing these tumors, and they're affecting both male and female equally. So the clinical presentation depends on the organ which has been affected. If it's the pancreas or pancreatic duodenal or anterior pituitary. So depending on the organ that has been affected, whether the parathyroid, depending on the organ and the hormones. So, however, they can occur synchronously, both in all the organs, or one or two of them. So most of the mutation carriers are identified in the screening program. Once you screen one person and it tests positive, then you can follow up with the familial in the family and assess the genes and the carriers in the family. So the affected organs, as I said, you have the pancreas and the duodenum up to around 50 to 80%, the parathyroids up to 90%, and then the anterior pituitary, as you can see. Sometimes we have some of them in the adrenal glands, but specifically for men 1, those are the three organs that are mainly affected. And the syndrome and the hormones, you can see the parathyroid hormone and the parathyroid hormone. Then we have the anterior pituitary giving prolactin as a manifestation, as the hormone of influence. Then we have the gastrin in the pancreas and the duodenum, the insulin. So these ones will give you the insulinomas. So, and the gastrinomas. So we go to the main one still presentation, specifically on the parathyroid. As I said, let me go back a bit. They're saying that there is primary hyperthyroidism as the clinical syndrome in the parathyroids. Well, the pancreas and duodenum, you have the Zollinger-Ellison syndrome, that is high release of gastric acids. And then also you have hypoglycemic states. However, I want us to note that the gastrine tumors are more in men 1, as you can see, giving Zollinger-Ellison syndrome, unlike in the sporadic cases where the insulinomas are more frequent than the gastrinomas. So I don't want to take much time here. In the parathyroids, we have primary hyperthyroidism, and it is usually the first manifestation. So this hyperparathyroidism in men 1 is a multiglandular disease. So all the parathyroids may be affected in this case, not only one of the glands. So it is similar to the sporadic disease, as in with no genetic constitution of the chromosome 11. So the presentation here is similar to that one, which is sporadic. The diagnosis is usually you have to take the levels of calcium and parathyroid hormone in serum and urine. So that was the parathyroid gland. The other one is the endocrine pancreas, which is the other. I said there are 3 organs that are being affected: the parathyroid, the pancreas with the duodenum, and also the anterior pituitary. So if we look at the pancreas, these ones are usually called the PETs, pancreato and pancreatoduodenal endocrine tumors. So they occur around 50 to 60% of the men 1 patients, meaning the other percentage occurs either sporadic cases or partly in men 2, as we shall see. So the high rate of the detection of these PETs has been attributed to improved diagnostic procedures like the endoscopic ultrasound scan. So these PETs are the most common syndrome associated. The men 1 PETs are the most common syndrome associated cause of death. Among all the men 1 syndromes, the one which is caused by the pancreaticoduodenal tumors, this one is the one which causes mostly death, because they are multiple and they, even after surgery, they recur. So in men 1, the most common tumor, as I said, is gastrinoma, followed by the insulinomas. But in the sporadic, as we shall see, the insulinomas are more frequent than the gastrinomas. So the workup in diagnosis, still you have to measure the hormonal levels, that is gastrin, insulin, polypeptides, and also imaging. So in the anterior pituitary gland, which is the 3rd gland being affected by men 1, it is found only in 30 to 60% of the patients. And they are mainly microadenomas. As we said, the hormone affected is prolactin, and others are non-functioning tumors. So they just cause pressure effects, but not hormonal changes. So the most prolactinomas can be treated with medication, and thus you may avoid operation. As I said, it also affects sometimes some adrenal glands, and especially in patients affecting 40 to 50% of the patients. But these ones are usually non-hormonal. They're not non-functioning adenomas. All right, so let's see how we can manage men 1 conditions. If it is affecting the parathyroids, you have to do total parathyroidectomy, including the cervical thymectomy, and or you can do three-quarters of the gland resection, and or you may leave 50% of the parathyroid, depending on the presentation or the amount of the gland that has been affected. However, if you do selective resection of the enlarged glands, you should do selective resection of the enlarged glands because of the high rates of the recurrence of these tumors. If it's the pancreas which is affected, you must operate this gastrinoma or insulinoma to prevent the metastasis to the liver, and also to control hormonal excesses. As a something to note here is that the gastrinomas are more in the duodenum as multiple small tumors than in the pancreas. In this pancreaticoduodenal, they are more in the duodenum than in the pancreas. So if the gastrinomas are located in the duodenum or pancreas head, which is what we call the gastrinoma triangle, it's recommended to do a pylorus preserving a partial pancreatoduodenectomy. So this is the triangle that I was talking about. You have the upper part of the duodenum and the lower part of the duodenum, as you can see, with the head of the pancreas. So that area with its lymph nodes is what we call the gastrinoma triangle. So the kind of surgery that I was saying that you have to do pylorus preserving. You preserve the pylorus partial pancreaticoduodenal duodenectomy. So still on the endocrine pancreas, these gastrinomas are rare in the body and the tail. So in such cases, you just do the distal pancreatectomy with excision of the tumor in the pancreatic head as a procedure of choice. If it is an insulinoma, the standard operative procedure is distal pancreatectomy with enucleation of the tumor in the pancreatic head. So in the enucleation, you preserve the surrounding organs. So the non-functioning pets, these ones, if the size goes beyond 1 centimeter, that's when you can operate. But if they're not giving any symptoms, hormonal symptoms, then you can leave it. So in this operation, you have to do careful palpation and you have to do intraoperative ultrasound scan. It's very essential if you are to, because some of the tumors are not visible by the eye. So you have to do intraoperative ultrasound scan. If we are looking at the anterior pituitary, the surgical intervention here, the indication for your surgery here in this tumor is the presence of the symptomatic. It's non-functional, but it is symptomatic. And in case the medical therapy fails, that's when you can go in for a transsphenoidal operational approach. The adrenal glands, these ones I said, they are usually non-functioning, and you can only resect if they go beyond 4 centimeters, causing other symptoms. Pheochromocytoma has to be ruled out in every patient with adrenal tumors. Mostly, you can do laparoscopic surgery in this case. So if you suspect as I said, they are usually non-functional, but if you suspect it's a malignant one, you have to go open surgery. Let's look at MEN2. The MEN2 ones are the mutation is in chromosome 10 with the red proto-oncogene being affected. So these ones are subdivided. The main one are not subdivided. These ones are subdivided into 3. But yes, into 3. That is the medullary thyroid carcinoma, which is usually familial. You have the MEN2A and MEN2B. This medullary thyroid carcinoma almost appears in all the 3 subtypes, type 1, type 2, and type 3. Rather 2A, 2B, and also MTC. So they are a combination. If we are to look at type A, which is 2A, you have MTC combined with the primary hyperthyroidism and mostly bilateral pheochromocytomas. So this is now a combination of many tumors affecting different organs. So if the MTC is combined with pheochromocytoma alone, that is a Sippos syndrome. But in MEN2A, you have all the 3 usually appearing. If it is MEN2B, you have MTC, a pheochromocytoma, and also oral mucosa involvement. You have oral mucosal neuromas or intestinal ganglioneuromatosis accompanied by the mafanoid habitus. So here in MEN2B, you have a number of conditions being affected or being involved in this. It's not only MTC and pheochromocytoma, but you have oral mucosal involvement. That is in men 2B. Okay, so it's almost, so you see that MTC is appearing almost in all of them, all the three presentations. So if it is pheochromocytoma with primary hyperthyroidism, if those two do not occur, you suspect familial type, which is type 1. Okay, so let's talk about this MTC. So in this men 2, unlike in MTC, which is sporadic, the diagnosis of this is usually look at the mutation that we talked about. And during screening of the calcitonin levels, you can follow up in families and look for this Rett gene. So it's the most aggressive of the men 2, MTC. It's the most aggressive. It occurs in childhood and much earlier even. So the preventive surgery, as long as you locate this gene, remove the thyroid. So in primary hyperparathyroidism, this one is less common, especially in the men 2 syndromes. But we saw it more aggressive in men 1. So it occurs in about 20 to 30% of the patients with men 2A, and most patients are symptomatic. But you have the genes for men 1, it is usually more aggressive. So in men 2, it develops after the 3rd decade of life. The frequency in pheochromocytoma in men 2 is around 10 to 50, and the tumors can be bilateral. So the tumors are always mostly benign. Remember, this is what comprises men 2A. You have the pheochromocytoma, you have the MTC, and also in men 2B, you have the involvement of the oral mucosa. So in pheochromocytoma, the diagnostic workup here, you must have the catecholamines, the abdominal CT or MRI, and scintigraphy. Let's operate these men 2 syndromes. If it is MTC presenting, here surgery is mainly or mostly prophylactic, because if you don't, 100% chances of developing this in those patients with the mutation. So whether there is evidence of the tumor or not, you have to operate. So they can have it can either be an early or late onset. The risk groups that have been defined to determine the appropriate age for thyroidectomy, you can see down there. If you measure and you find that the patient has a very high risk, you can even operate below 1 year. You can see the table there. And then also, if you classify him as a low risk, as long as it's below 20 years, you can still operate. So if it's a pheochromocytoma, the approach is laparoscopic. And either unilateral, bilateral, subtotal resection may be done, reducing the postoperative dependence on cortisol. So you can do a partial resection so that you don't truly depend on these supplements. Okay. So if it is primary hyperthyroidism, this is, I remember I told you, more difficult presentation than in men 1 because of the association with MTC in men 2. As I said, if it presents alone, it's less aggressive, but when, like in men, but less aggressive when it presents alone in men 2, but more aggressive in men 2 if it presents with MTC. So there you have to remove both the thyroid and the parathyroid. So during your next surgery for MTC, even when the calcium levels are normal, and yet the glands are enlarged in hyperparathyroidism, you just have to remove also the parathyroid glands. So that marks the end of our men 1 and men 2 as syndromes or inherited syndromes. So let us look at sporadic tumors, but they are also similar to the ones that appear in men 1 and men 2. So among these, we want to look at the NETs of the stomach, or neuroendocrine tumors of the stomach. Are we together? Are we still together?
Yes, yes.
Okay, okay. Thank you so much. All right, so among the ones of the stomach, the neuroendocrine tumors of the stomach, these ones are very rare. And they only comprise around 5% of all the NETs of the GI. So the cases are, the NETs we have the ones of the small intestines, we have the ones of the stomach as we are looking at them, and the pancreas, the duodenum, like that. So these ones comprise only 5% of all the GI tract NETs, and they are very rare, only around 0.2 cases per 100,000 population per year. However, they are divided into 4 types. There is type 1, type 2, and type 4, type 3 and 4. Type 3 and 4 are the ones which are more aggressive, and but type 1 and 2, they are benign tumors that just arise from the ECL cells in the mucosa. The type 3 and 4, they are the ones which are usually malignant. And these ones, you must do a surgical resection. So the size is usually for type 3 around 2 centimeters, but type 4, they carry different sizes. The prognosis for this type 4 is very poor. And they are sporadic with no known cause, no specific known cause. So in type 1, among the neuroendocrine tumors of the stomach, it's type 1 which is most common, and occurring mostly in elderly women. So you have chronic hypergastrinemia causing chronic atrophic gastritis. Sorry, you have chronic atrophic gastritis causing aclohydria, and because of the increased pH, alkaline pH, causing so, and that is how you have chronic hypergastrinemia. And it is usually asymptomatic, detected during endoscopy. So if you detect these tumors, you can resect them on endoscopy. You can do surgery if there is a recurrent disease and more than 6 tumors, with at least one of them measuring more than 1 centimeter, and infiltration into the submucosa. So you have a stomach layer that is releasing more of the gastrin, causing peptic ulcer signs. So this is what happens in these patients. And it is usually because of the chronic release of these gastrin levels. You have low pH in these patients who are elderly, and in the rebound release of gastrin, causing these symptoms. So if the in the type 2 tumors, the pathogenesis is the same, like as those in type 1. You have the elderly, there is atrophy of the gastrin layer, and then also rebound release of gastrin levels. So the cause of this hypergastrinemia in these ones is the result of men 1 syndrome with multiple gastrinomas in the duodenum, but rarely in the pancreas. So type 2 has a form of genetical composition. The type 3, these ones are rare, sporadic and solitary tumors of the unknown origin. So you have gastrin levels here are normal. And the usual symptom we are having is upper GI bleeding. So the tumors are usually larger than 2 centimeters, as I had said or mentioned before, and they have metastasis, very aggressive. That is type 3 and type 4. So the gastrectomy and lymph node dissection and resection of the liver metastasis is the treatment of choice. So you can also do chemoembolization in liver metastasis. Well, the type 4, these ones are large ulcerating malignancies, similar to adenocarcinomas, and should be treated depending on their size. So the prognosis, as I said, for 3 and 4 is very poor. So those are the nets of the stomach. Let us look at the nets of the small bowel. So these ones are the ones which are usually referred to the carcinoid tumors because of their clinical manifestation. Some call them the midgut tumors, and why they produce serotonin, and they cause the carcinoid syndrome with a large volume of liver metastasis. We shall look at the carcinoid syndrome with how it presents. There are usually clinical manifestations, if you can say, of a cancer patient. So we have large volume of liver metastasis and advanced local tumor growth draining into the IVC and thereby bypassing the liver. That's the inferior vena cava. So the duodenum, the nets of the duodenum, we have the gastrinomas in MEN1 syndrome, somatostatinomas, and others, but these ones are very rare. Okay, so briefly, still on introduction, if the nets are in the jejunum and the ileum, these ones are raised from the diffuse neuroendocrine system, the EC cells, which secrete serotonin and substance B. These ones are usually solitary and more often multiple. They are always malignant and metastasize at an early age. So you can see, okay, you can see the diameter of the tumor vis-a-vis the frequency of the lymph node involvement, that is metastasis. So whenever it's in these tumors, the size of the tumor, usually with the higher the size of the tumor, the higher the chances of metastasis into lymph node and liver involvement. That is all that the table is showing. They are seeing the tumors of the small bowel, same picture with the diverticulum, the appendix, same picture with the colon and the rectum, much as at a lower size of the appendicular, the lower size of the appendix tumor can even give metastasis into the lymph nodes. Okay, so the symptoms in these tumors are either at the size causing the primary tumor size effects, but also on the lymph node metastasis. So the signs can be acute or chronic, can be recurrent or persistent abdominal pains with the ileus, and rarely lower GI bleeding can occur. So sudden painful reddening of the face, the chest flushing, diarrhea and bronchospasms due to the liver mets. So these are the symptoms which constitute the carcinoid syndrome. So about 60% of the patients eventually develop cardiac symptoms because of the stenosis and insufficiency of the pulmonary vessels with enlargement and thickening of the right atrial wall. So, but initially you have symptoms specifically of diarrhea, bronchospasms. You have these patients having chest pain. So this is what we call the carcinoid syndrome. So still on the abdominal symptoms, they can be caused by the obstruction of the appendix, as I said, in the appendiceal net, leading to appendicectomy, or by obstruction of the mesentery, or the bowel lumen because of the growth of the lymph node metastasis in the mesentery. So depending on the size and the metastasis of the tumor. So the pain that these patients feel is usually caused by the ischemia of the bowel, resulting not only from the mesenteric lymph node metastasis, but also from the constriction of the mesenteric vessels. So a condition that is called the desmoplastic reaction. So the primary tumors in the jejunum and the ileum, they rarely cause symptoms such as bleeding or intussusception because of their size, because they are usually less than 2 centimeters. A poplite neuroendocrine tumor of the terminal ileum may, however, cause ileocecal intussusception because of its size. So how do you diagnose these conditions? These NETs have to take history, have to do a physical exam, imaging. We looked at some of the imaging. Endoscopic ultrasound scan is one of them. And then also serotonin levels in the blood in the 24, also in the 24-hour urine sample. So this test is positive. For example, imagine in larger tumors, if metastases are present. The best method for this is a test that they called the octreotide scan. So it shows all tumor if large enough and has a high somatostatin receptor density. Okay. So when do you do surgery? It is indicated even in the presence of liver metastasis. So you don't withhold surgery even when you have metastasis to the liver. You can resect up to 100 centimeters of the bowel, particularly if stage 3 or stage 4 lymph node metastases are found in the mesenchyme. The liver metastasis can be treated. So the other surgery you can do to relieve the symptoms of obstruction, but also you can do chemotherapy, chemoembolization of the liver metastasis. So these are the stages, as I'm telling you, the mesenteric involvement at stage 1 and stage 2, more vessels are involved. Stage 3, vessels are involved at a higher level, affecting a bigger portion of the gut. And stage 4, almost the superior mesenteric artery is the one which is involved, cutting off blood supply to the big portion of the jejunum and the ileum. So, but as I said, depending, irrespective of the stage of the involvement, surgery should not be contraindicated, irrespective of the metastasis. So you can also do medical management with somatostatin or its analogs for the treatment of the carcinoid syndrome caused by the large volume of the liver metastasis. So these drugs may also have an anti-proliferative effect, limiting the growth of the tumor, and surgery to remove the liver metastasis, if possible, is possible in approximately 10% of the patients. So if not, you can do chemoembolization of the metastasis in the liver or liver transplant. Let's look at the PETs. The other ones were the NETs. So in the PETs, these ones, the pancreatic duodenal, we had mentioned them in the main syndrome. We had mentioned them in the main syndrome, main one actually. But they can be sporadic. They may not be inherited. They can be just sporadic. And these ones are accounting for only 5% of the clinically detected pancreatic tumors. They can be single or multiple, benign or neoplastic or malignant, and associated in 10 to 20% of cases with men 1. As I said, they were also mentioned in men 1 syndrome. So they can be functional or non-functional. Functional meaning they have a hormonal contribution, or non-functional, only the symptoms are caused by the size of the tumor. So this section focuses mainly on the insulinomas. As I said, in men 1 syndrome, the gastrinomas are more frequent, but here in sporadic, the sporadic PETs, the insulinomas are more frequent, and also non-functioning tumors. All right, so you can see in this table, the most incident here we're having, the insulinoma. But it carries a less malignant, it is less malignant than the gastrinoma, much as it is more incident. The gastrinoma comes in third in incidence, secondary to the non-functional tumors. Okay, other hormones produced by the pancreas, you know, but we will not focus much on them because of their less prevalence. So as I said, the pancreas has many cells. We have the beta cells producing the insulin. We have the alpha cells producing glucagon and delta cells producing somatostatin. The pancreatic polypeptide cells containing polypeptides. So majorly here we have the beta cells which have been stimulated and they're the ones giving off the insulinomas. So in the insulinomas, the name suggests, they produce insulin, and their clinical presentation is what we call the Whipple's triad. The Whipple's triad has three things. You have the symptoms of hypoglycemia. This patient presents with symptoms of hypoglycemia. I think we know them: the blurring vision, the dizziness, the weakness. So the patient has symptoms of hypoglycemia. But also when you take a glucometer and measure, the patient actually is hypoglycemic with the levels most times less than 2.8 millimoles per liter. But when you give glucose, IV glucose to these patients, the symptoms are relieved. So it is just playing about the levels of glucose in the blood. So, and this thing is the most frequent among the functioning pests, as I say, affecting 2 to 4 cases per million population. All ages are affected, however, more prevalent in the females than in males. What happens exactly is unknown, but all these insulinomas are located in the pancreas, and the tumors are equally distributed within the gland, not head or tail, but almost equally distributed. 90% of them are solitary, and 10% are multiple or associated with the main one syndrome, as I had mentioned. Prognosis: there is no available marker to really predict the behavior of this thing. 10% are usually malignant. As I said, the gastrinomas are more malignant than the insulinomas. So it's usually less than 2 centimeters in diameter without any signs of vascular invasion or metastasis. Mostly, as I said, it's less malignant. So how do you investigate it? There's a test called the fasting test. And up to 72 hours, you let this person fast for up to 72 hours. And within that time, you do a 1 to 2 interval measurement of insulin levels, proinsulin, and C-peptide, and the glucose levels. So you will realize that there is high secretion, even when the glucose levels, because this person is fasting, the glucose levels continue lowering down, but there is persistent increase or persistent secretion of insulin, even when the glucose levels are going down. Ideally, in the normal patient, you're supposed to have a reduced level of insulin as the levels of glucose go down. But these patients, you have persistently high secretion of insulin, even when the glucose levels keep on going down. So, and also you'll find that there is elevated peptide levels, C-peptide levels, and this one excludes hypoglycemia if it was caused by insulin injection. All causes of hypoglycemia will be our differentials. So sometimes it is difficult to differentiate insulinomas from other causes of hypoglycemia. So you must rule out. So the treatment, you can give, the ideal treatment for these things is get in and remove the tumor. But if surgery is not possible, there are some drugs like diazoxide. For example, if the patient declines surgery, or there are metastases. So you can start with treatments like diazoxide, which suppresses insulin secretion. The other options are chemotherapeutic drugs like azaruxibine and streptozotocin. So, as I said, if possible, do the surgery. So indications for operation, you have a positive fasting test, you have no metastasis by your ultrasound or CT scan, and you advise these patients to go for surgery to remove this tumor. Other studies for preparation for your operative procedure, the most sensitive is the endoscopic ultrasound. It detects up to 65% of these tumors. So, but if you go in still without, for example, maybe if you did a CT abdomen and you reach inside there and you are not clearly visualizing this tumor, you can do an intraoperative ultrasound scan the pancreas during your laparotomy. The benign ones, I said, they are the most ones common, and once you do surgery, they have a 90 to 100% cure rate of these tumors. So at open surgery, an extended posture maneuver can mobilize the head and then the distal pancreas to explore the whole gland. And as I said, the intraoperative ultrasound scan is very important to confirm the tumor and also to find the ones which are not palpable. So usually enucleation of this is the technique of choice. Just get it out. No, you don't affect the surrounding organs. You just enucleate the tumor. Okay, so if that's located deep into the body or the tail, you can do distal pancreatectomy. So you monitor the blood sugars immediately after operation. For example, in distal pancreatectomy, most of these patients will show there will be something to show within the first few hours after the removal of the tumor. So if you can't localize the tumor, please don't do blind resection because you'll cause iatrogenic hormonal insulin levels, disturbance in insulin levels. So malignant insulinomas, these ones are aggressive. I said they're only 10%, but you can attempt resection of these tumors. So that marks the end of our presentation on the men syndrome and also the NETs and the PETs. Thank you so much.
Thank you so much for that presentation. Very precise. May I receive comments, additions, subtractions from the team? We are 11 of us, so I need people to talk.
Morning.
Good morning.
Yes, I would like to ask a few questions.
Go ahead.
Yes, in case the whole parathyroid gland are involved, so we have to remove the four. We have to remove all of them.
Ask again. I didn't get the question. Well,
in case the four parathyroid gland are involved, when we are going to do the surgery, are we going to remove all of them, or in case we can leave one and monitor?
now the parathyroid disease in multiple endocrine neoplasia is usually a parathyroid hyperplasia other than a parathyroid adenoma. It is much more difficult to deal with hyperplasia than an adenoma. Adenomas are quite solitary and easy to remove. So when there is hyperplasia, the rate of recurrence is very high. Ideally, the best is to remove 3 and leave 1. So even that one, he gave you 3.5. Even that one that remains most often will produce a lot of parathyroid hormone to cause hyperparathyroidism. So you cut into half. And as I said earlier in our previous discussion, the best is to implant it in the brachioradialis. So that should the hyperparathyroidism occur again, you just go under local anesthesia. You don't need an anesthetist. You infiltrate the area of the brachioradialis and chop off a bit of it, implant a little more so that the patient is not on medication. So you play about with the one parathyroid or half parathyroid that you are left with in the brachioradialis or in the sternocleidomastoid. But the preferred site is the brachioradialis because of the ease of removal should the hyperparathyroidism occur. So to answer your question, you remove 3 of the 4, and the one that remains, you can decide to either cut it into half and leave half depending on the level of hyperparathyroidism, or you implant the whole of it, and preferably in the brachioradialis. Any
Thank
other
you.
question? Any other question? Okay, if there are no questions, I wish to thank the presenter for the quite elaborate presentation. You just remind yourself that in men 1, you have the triple P, pituitary, parathyroid, and pancreas, and those are the organs that are affected. In men 2, you have the men 2A, 2A, 2B. You have multiple other endocrine diseases. What you need to do is whenever there is an endocrine problem, endocrine disease, be it pituitary or or in the other or parathyroid or even thyroid, try to look for other endocrine diseases so that you avoid or you prevent problems of managing one, then you realize, oh, there's another problem. Recently, I got a patient referred to me by the neurosurgeons who were managing a craniopharyngioma, which was giving her actually gigantism. She had the acromegaly. So he had a very big goiter. But when I investigated, the bigger portion of the goiter was actually in the chest. So it formed like a sort of figure 8 of a thyroid gland, the bigger portion being in the chest. So I advised her to go where they can do a median sternotomy so that goiter is removed. But she had all the features of acromegaly and this and the big goiter in the neck. Other glands were not affected. So always look for other endocrine, especially if you have the rare diseases, parathyroid, insulinoma, or adrenal diseases. Look for other endocrine problems. For the NETs, always be suspicious. Any patient who comes even with acute appendicitis, don't take the appendicitis for granted. Always have the appendix examined so that you avoid doing surgery which is not extensive enough. Most times the patients will come asymptomatic, but sometimes they come already with mets in the liver. But as the presenter says, even if there are mets in the liver and you recognize that there is a focus in the gut, go and do your resection. I have one patient who had mets in the liver, and the surgery was done almost 6 or 7 years ago, and is still living. And I have another patient who had mets in the liver, but the primary site could not be found, and that patient was given chemoradiation. Well, she lived for some time, but I think she got the effects of the chemotherapy with which caused a lot of immunological reaction, and her immunity went down. She got overwhelming sepsis, unfortunately, and passed on. In that one, we could not think of any surgery because the only thing we were seeing was mets in the liver. We tried to look CT, MRI, but the primary site could not be found, so we couldn't do any surgery. And for insulinoma, a number of the patients, especially the young ones, may be taken for a mental problem or mental disturbance because of that craving for sugar. They crave for sugar. The mothers can think that their sons or daughters are stealing the sugars, then sometimes even punish them or beat them. Then they end up in a mental unit because, of that stealthily getting sugar. And because they start getting some mental derangement because of the chronic hypoglycemia, they may be admitted into a mental unit. I think we had one of the kind, only to do ultrasound, and this young gentleman had an insulinoma. If the tumor is sizable, big, maybe 2 centimeters or above, it is actually easy to palpate it more than 2 centimeters. But when it is less than that, even that ultrasound, intraoperative ultrasound, may not pick it, because most times the pancreas looks like a lipomatous tissue. So even when you palpate, sometimes you palpate a, a fat tissue which feels like a lobule. You fail. In one patient, actually, we went in, looked for it, failed to get it, did an intraoperative ultrasound, also still failed to locate the tumor. So I think our manipulation now threw her into diabetes, but it is easier to manage a diabetic patient than to manage a patient who has insulinoma. So after resection, she became diabetic, but it was better to manage her as a diabetic than somebody who is disturbing you with the injection of dextrose now and again, or she had to move with the with the with the glucose in her bag all the time. So your colleagues in Chiriandongo told me they would be coming, but they never came. They missed a very nice case. We had one parathyroid adenoma who was sent to us, and we did the parathyroid surgery. It is a very interesting surgery because of the dramatic drop in the PTH after you've removed the adenoma. So they missed that case. I hope next time when they ask me to come, they actually come, or else you miss because for those 2 days I had about 6 surgeries, 4 thyroids, 1 breast, and 1 parathyroid. That would have been a good exposure for them. But I hope that next time when you ask to come, you actually come. Otherwise, you miss out. So unless there are any other questions and additions, I don't know. I'm going to travel today. I'll be traveling, and so I'll not be able, in case